Hi, everybody. It's Dr. Kerry Reller, your host of the Get Healthy Tampa Bay podcast. Welcome back. This week, we have Angela Fishman, a licensed physical therapist, to talk to us about her specialty. So welcome, Angela. Why don't you tell us a little bit about who you are and what you do?
Sure. Thanks so much for having me. Yeah, I'm a physical therapist, and a lot of people don't know what a pelvic floor physical therapist is. So I'm a physical therapist that specializes in the muscles of the pelvis. I help women kind of fix their pelvic floor problems so that they can really live life to their fullest, because problems in the pelvis are pretty devastating, or can be pretty devastating. It includes things such as leakage on the way to the bathroom, or peeing a little when you cough or sneeze, or exercise, or kick a ball with your kids, or pain with intercourse. Sometimes it's simpler. Sometimes it's you've just had a baby and you want to strengthen those muscles and kind of get back to your kind of pre-pregnancy state so you can exercise and feel good and get rid of your back pain. So it kind of runs the gamut. It addresses a lot of different things, but the core of it is really kind of understanding the muscles in the pelvis and their role and how it connects to all the other muscles in the body to make you feel better in that area.
Awesome. Well, I know you have a little bit of a unique practice style. So why don't you tell us about that?
I do. I treat solely remotely. So the way that actually came about was before, like literally right before the pandemic, I was becoming an empty nester, and my husband and I like to travel. And so I was trying to think, okay, I've been doing pelvic therapy for like 20 years. How do I continue serving this patient population? Because you won't find more passionate people than pelvic therapists. We love helping women in this area and men, but women is particularly what we're talking about today, because it just makes such a difference in their lives when you fix these issues. And so I was kind of brainstorming, and I kind of came up, I could do telehealth. And so then the pandemic hit, which kind of fed right into that plan nicely.
Absolutely.
I obviously wish we didn't have a pandemic, but I have to say it was really helpful, because I thought I was only going to be able to treat bladder problems. I really went in thinking, okay, if I can't touch somebody, I'm just going to have to educate them and tell them what to do. And then the pandemic hit, and you had to treat everybody via telehealth really at first. And I realized like I could treat almost everything. And it was such an eye-opening experience. And it took some practice. Don't get me wrong, it wasn't easy. I was so used to putting my hands on patients and assessing that way that I really had to use my eyeballs more and really understand, how are you moving and why are you moving that way? And maybe it's because this is tight or that, and kind of testing and working with patients through this medium. And I have found it much more effective, to my good surprise, just because we had to go through the pandemic. So yeah, another kind of motivation and kind of justification for me thinking that telehealth would be great is that over the years, it's such a barrier to get in to see somebody for pelvic therapy. It's this very intimate, embarrassing, very isolating problem. And it's hard to get yourself to walk into a clinic. It's full of other people that are dealing with their knee and their hips and their shoulders. And you, oh my gosh, I got to do my pelvic floor. What does that even mean? So it's pretty intimidating. So telehealth really kind of helps to ease all of that. You're in the comfort of your own home. You can have your spouse or partner with you. You can have a friend holding your hand if you want. I mean, it's so much more quiet and intimate. And you have the confidence that I'm not going to touch you, which really helps people relax. They're fully dressed the whole time. There's none of this, what is she going to do down there? That's just all gone. And so it's really kind of helped lower the barrier for people to access services and feel more comfortable with the services as well.
That was absolutely one of my questions of what can you do, or how can you make patients who are kind of timid or afraid to go address this problem, and how can you help them overcome their barriers? And I guess your answer would be telehealth. So that's definitely answered that question already. So I really like that. I know you've kind of briefly mentioned this already, but what kind of problems do you treat as a pelvic floor physical therapist?
Yeah, I would say the most common ones are going to be bladder issues, which is actually an umbrella term for a lot of things. That could be leaking when you cough or sneeze or exercise, rushing to the bathroom, going frequently and having to know where every bathroom around town is, waking up at night and having to empty your bladder more than once a night. So all of those kinds of things really come under the pelvic floor therapy kind of umbrella for bladder. So that's a big one. A lot of postpartum rehabilitation. Some women who are pregnant have quite a bit of pain as they're advancing in their pregnancy because of the weakness and the changes in hormones and the changes in, there's less and less, all the ligaments that are going to help you give birth to the baby, they're loosening a little so that you can give birth. But that takes away a little bit of stability and support for some of our joints. And so a lot of times it's pretty common for pregnant women to have pain. So there's things we can do there to strengthen muscles. And there's lots of questions. Women are becoming more and more aware of their pelvic floor as they're going through having a baby. And they want to protect that area. They don't want to tear. They don't want incontinence. They want to get back to their pre-pregnancy self after they have the baby. So there's quite a few things, or quite a few people that I see kind of in that pregnancy, right after birth, and then postpartum period of time as well. Pain with intercourse is another really big one. So many women don't even know that it's not supposed to hurt. They'll tell me things like, well, that's just my pain. It's always felt that way. Like they just don't necessarily know that that's not quote unquote the norm. So I see quite a bit of that. And then some prolapse. So if someone's got a mild, like grade 1, grade 2 prolapse, physical therapy and learning how to manage pressures, that can really help to manage the symptoms of prolapse. So when you cough or sneeze, what do you do? When you lift something, how do you use your body correctly? When you open a heavy door or pick up a gallon of milk, what are some simple strategies you can do to kind of protect that area and strengthen the muscles around it?
Yeah, I mean, I guess we should get into specifics. So basically going into postpartum, you mentioned the ligament laxity that happens when you're pregnant. So how do you help them strengthen those muscles in the postpartum period?
Yeah, so I do a workshop where we kind of talk about what do you do right before you have the baby?
Mhm.
What do you do right after the baby, like those first few days to a couple of weeks? And then how do you progress from there? Because those 3 stages are actually kind of different, right? Different things are going on, and there's different expectations for your body through there. So you're trying to impart, how do you strengthen your pelvic floor muscles if strengthening is what you need? So kind of a sidebar of all of this is that some people don't need to strengthen their pelvic floor. Some people have so much tension and tightness in their pelvic floor, they actually need the opposite. They need to figure out how do they relax and lengthen those muscles so that they can use those muscles better. So while we always, it's most of the kind of lay person conversations are surrounding how do you strengthen the pelvic floor, but there is quite a big subset of people that actually need the opposite. They need to lengthen and relax those muscles. So what's the right thing to do for the pelvic floor muscles? The deep abdominals are so important during this stage of life because, well, first of all, while you're pregnant, they're being so stretched. And then you have to get ready to be able to have the baby. So there's some preparation there that we can work on. And then after you have the baby, now all of a sudden they're just hanging there, right? And they have to really kind of reknit themselves and shorten and become powerful again. So depending on what stage they're in, we work with that. And then finally, that third thing we already mentioned is just how do you deal with pressures? So many things that go wrong with our pelvic floor are pressure oriented. So you have all this coughing pressure coming down, or lifting, holding a new baby, and there's pressure coming down. And if you don't engage in the bottom, in your deep core, as well as these deeper abdominals to kind of support this area, sometimes that can contribute to these symptoms that you might be having. So those are kind of the 3 areas that we focus on. And then if someone has something else, maybe they have a bad hip or a knee problem or something else, or they have a history of back pain, then of course we'll address that as well.
So how do you assess virtually whether you need to lengthen and loosen up versus tighten?
Yeah, great question. So really, really careful questioning is the first thing. People that have a tense pelvic floor tend to have a really specific history. A lot of times there's pain. So pain can be pain with bowel movements, pain with emptying a bladder. They have tailbone pain. They might have constipation, which can be a sign that the muscles are too tight. They might have pain with intercourse. So kind of questioning them, if you think of the pelvis kind of with 3 openings from front to back in a woman, you're asking questions about all 3 of those areas and getting an idea of how they function. And those answers can very specifically tell you whether or not you're thinking, oh, okay, she might kind of be in this tension side versus this weakness side. And what else has happened? If someone has just had a baby, they're going to be more likely to have weakness, but they might be tense and have tension too. So you kind of take in their medical history into account as well as you're asking those questions. And then after I've talked to them, I know, okay, I think she's here, but let's test it because maybe she is here. And then I see how you move. Because if you do have tightness in your pelvic floor, you might stand with your butt tucked under. because your tailbone's being pulled under and all that tightness is pulling together. So I can see it when you're standing. Or you might not have very flexible hips, or your back might be tight. There's different orthopedic things that can lead me to think you might have tension in your pelvic floor. Maybe your hamstrings are really, really tight and your groin muscles are tight and your piriformis muscles are tight. So you can test all that really easily visually through the computer. And then that helps you kind of confirm or not confirm whether or not your guess was right initially.
So do you have them get in certain positions and stretches during the visit?
Yeah. So first of all, I meet with everybody for a free 15-minute consultation ahead of time because I want to make sure they're comfortable with the medium, they're comfortable with me. I make sure that they're a good fit, for what we're going to be doing. I had a woman last week actually who was in her 30s and she's never had a pelvic exam and she's coming to see me with pain, right? So if you're coming to see me with pain and you've never had a pelvic exam, I'm not comfortable where we're at. I need you to see a physician first. So I can, counsel her and she'll be seeing somebody first before I see her. So you're using that 15-minute period of time just to make sure that we're a good match for what we're trying to do. But then I let them know when we're meeting, I'm going to want to see you in sitting for a little bit, in standing, and then laying down. So that automatically ahead of time, they've already kind of prepared the space of where they're talking to me in so that they can get into those positions. And I can ask them to do all of those things.
That makes a lot of sense. Obviously, if they haven't seen any physician yet, it's probably a good thing to be ruling out any other cause first. Absolutely.
Exactly.
Yeah. So how about for specific exercises for the strengthening? Do you recommend certain things?
Yeah. So I can't give you like one exercise. Like people want me to say, yes, do Kegels, right? So Kegels, there's like so many myths around Kegels. I liken it to what other part of our body would we ever accept the fact that one exercise will fix every problem? Let's say you have a shoulder problem. There is not one exercise I could give you because think of how many shoulder problems you could have. I could have a rotator cuff strain. I could have a nerve pinched in my neck. I'm going to give you all different exercises to make this better. And the pelvis is no different. However, that being said, Kegels can play a very important part in rehabilitating this area if you're on this weakness side of things that we were talking about. And many, many women come to me and say, well, I've already tried Kegels. They don't work for me. So the other piece to know about Kegels is this. And first of all, just to say what a Kegel is just a pelvic floor muscle contraction. We should probably say that, and a relaxation. So just how you could, flex your biceps and relax, you're moving your arm that way. That's all a Kegel is contracting your pelvic floor and relaxing. But when you do that, how often do you do that? How long do you hold that? How many weeks in a row do you do that? Nobody knows. They're like, well, I don't know. Nobody showed me how. I do a few when I think of it. That is the most common answer. Well, that's not going to hurt you, but it's not going to make a change. You want to transform your pelvic health, right? So that's not going to make a change if you're not doing like full sets to really fatigue the muscles to get them to get stronger over time. So I call it a prescription. We're going to prescribe exactly how often you need to do this and how often you need to increase how much you're doing over time so that you get that improvement over time.
And how do you know if they're doing it correctly?
Yeah, that's probably the biggest challenge, but I've been doing it long enough that I can watch somebody. So usually we start lying down, knees bent on the floor, bed, or couch. And first we'll talk about it. I do a lot of education with a model so that they're understanding physically what the muscles are. And we talk a lot about visualization. If you're sitting on a toilet and you're urinating and you try and slow the flow of the urine, those are the muscles that you're trying to contract. And so kind of using that visualization, most women can then, in that position, go ahead and try and contract those muscles. And I can watch if their butt rises, if their stomach pushes out, there's like cues you can watch because I should not see anything. So if I see these other cues, I know they're not doing it right. So we back up and we talk about other ways to visualize it or other ways to try it until we're confident that they can do it. And once they're more confident, they'll reassure me, yep, I can feel things coming up and in, or I can feel things tightening, because it's a little easier when you're lying down and you don't have all that pressure on your pelvic floor. So it's not 100% science, but it's pretty good. I'll tell you, that's what I learned during the pandemic. And then I know what to expect down the road. So if I give them Kegels and they come back and they're worse, okay, wait, we got to back up. Something happened. Let's come back to how do you actually do them? But in general, they do great with it. So it's worked out better than I thought without being able to actually feel those muscles.
So I've also, not to be speaking inappropriately, but also heard another way to think about doing the Kegel is by holding in the fart. I don't know if you've heard that
Sure.
way of teaching either.
Yeah. And so the problem with that one right off the bat, I usually start with urine because most women that I'm seeing, they tend to overuse their gluteal muscles. So if their pelvic floor is really weak, your butt muscles are going to come in to try and help because your body really wants you to be successful and they try and squeeze. And the problem is they're not lined up around our sphincters. They're kind of lined up in the wrong place. And so they don't really help. So if someone has weak pelvic floor, the first thing they're going to do is squeeze their butt. So if I'm also telling them, picture holding back gas, it kind of feeds into that overuse of their buttocks. So I usually will start more forward in the pelvic floor, the visualization more around the urine, but you can absolutely use any cue. Some people like to use the cue of you're picking up a marble with your vagina, which that one kind of freaks me out. Like, I don't know if I'd want to do that, but some people respond to it. Everyone responds to different things. You have to have like different cues for different people, but I try and start a little more forward to try and keep the bottom a little more quiet because usually those are overactive in somebody that is having some pelvic floor weakness.
Now, with the exercises, sometimes when I'm teaching patients about physical therapy, I'm like, well, great, you need to go to all these sessions, you need to learn the exercises, but guess what? You're probably going to have to continue these for your whole life. Is it the same way with pelvic floor therapy exercises, kind of like the Kegels?
Well, I think as a healthcare provider, it's good to know the research, and the research says people won't keep doing them. So you have to know that ahead of time. So what I tell people is like, okay, after I finish their evaluation, I have a pretty good idea of knowing what the expectations are. So let's take a bladder, since we're talking about bladder a little bit, let's take a bladder situation with someone with weakness. We know just physiologically, you're going to have to exercise about 6 weeks to see some good strength gains in those muscles. So right off the bat, I'm telling them, okay, I need you to think about 6 to 8 weeks to really see significant change. Now, you might see some improvements in 2 weeks just because you're learning how to respond to the environment in a different way. You're learning how to pull your muscles in a little different way. And most people do in a couple of weeks already will come back and be telling me, oh, this was a little bit better. But I want them to think through those 6 to 8 weeks, because that's probably about the time they're going to need to really fully meet their goals. And for some people, it might be even longer. If you come to me and you've had stress incontinence for 10 years versus someone who just had a baby and is leaking a little with coughing or sneezing, my expectation is going to be probably different for how quickly they're going to meet their goals with what they're doing. And then when we're kind of getting close to being done with therapy, then I teach them, all right, here's a maintenance schedule. Instead of doing it every day, maybe it's 3 times a week, or I kind of guide them that way. And knowing that the research tells me they're going to stop doing it, right? If they're not having symptoms, they're not going to do it. I always have them keep their exercises. And I tell them, especially with bladder, pelvic floor problems tend to recur. Stick it in your drawer and know where it's at so that when you do get the flu and you've thrown up 10 times in a row and your pelvic floor has kind of weakened and you're leaking again a little, when you feel better, pull those exercises out because now you know how to do it. So my job is to kind of empower them so that they do know how to do it on their own in the future. And they can always come back if they need the assistance, but they might not need to because now they know how to do it.
Right, right. So you mentioned a couple other things. Can you explain the connection between the pelvic floor and the sexual health?
Sure. There's lots of reasons you could have, for instance, pain with if we're talking specifically pain with intercourse. We can also talk about other ways that the pelvic floor muscles can enhance pelvic floor function, right? Because the muscles of the pelvic floor are involved in arousal and in orgasm too. But what we tend to see the most in the clinic is going to be pain with intercourse. And so you might have skin issues that cause pain. We need to know that, right? But then pretty close in that you're at the muscle level already. And if those muscles, whether it's the superficial layer of the pelvic floor muscles or the deeper layer or both, those can impact whether or not you're going to have pain with intercourse. And there's kind of two. So the technical names are, one's called dyspareunia, which literally means pain with intercourse. But then there's also kind of this subset called vaginismus. And vaginismus tends to be more fear-based. There's been some experience, not always, but there tends to be this fear cycle that's happened. I attempted intercourse. I couldn't do it. It might have hurt. It felt like something, they were hitting a wall. It just doesn't work. What is wrong with me? And so vaginismus pretty quickly kind of snowballs into this, how do I deal with this? What is wrong with me? And it's a very isolating experience for most women. And it's very difficult in a relationship, as you can imagine. Versus dyspareunia, a lot of people with dyspareunia will have had a period of time where they've had no pain with intercourse. Something happens. Maybe they had a baby and they had stitches, or they fell on their tailbone and the muscles went in spasm, or something happens. And now they have pain with intercourse. And these are generalizations, but that tends to be a little bit more physical based. Let's fix the physical problem that's going on to get you back to being able to have sex without pain. So there's just a lot of interviewing of a patient to just figure out, how did you come to me today with these symptoms, so that we know how to kind of unravel them. And maybe we need to get other providers involved. Maybe we need, if you've had trauma, have you dealt with that trauma? Do we need to have a therapist that you're seeing at the same time as we're working on these very intimate muscles, so that you're okay during all of this? So that's kind of our job at that first session, is to really see what are all your needs, not just these muscles. You're a whole person, so we want to make sure we're addressing the whole person.
Yes, that's absolutely important. I think, especially when you bring in the mental health aspect of it too, because that could be the underlying barrier to
Absolutely.
having their problem. Yeah. So are there any specific strategies that you use for that other than multidisciplinary care?
Specifically for pain with intercourse?
Yes.
So dilators are something that we often use, especially like I was saying, for me via telehealth. Dilators can be something that is a super helpful tool for somebody. And what you're doing there is you're kind of breaking down intercourse. You're pulling apart your partner, not involved right now. It's just about you. Okay. So there's no pressure from somebody else. It's just you. Now let's get to know your body a little bit and let your body realize that you can have touch there without pain. So our first goal is to figure out, what kind of touch can you tolerate there without any pain? We can't introduce something like a dilator that's painful, because you're just going to rebuild into the system that fear-based, pain-based reaction. And we don't want to do that. I've had women that could only take a Q-tip and touch the area. And that, if that's where you start, that's where you start. And that's fine. You're trying to get to where they can tolerate something so small. There's zero pain. It's almost boring. I always tell them, if you can get bored with something, that's great, because then you're going to want to go to that next stage, something a little bit bigger. So dilators there's lots of different kinds, and they're in graduated sizes. Some are flexible, some are stiffer. It really just depends on what we're trying to achieve. But the general concept is working up over time with as minimal pain as possible, so that they're really regaining confidence. And subconsciously too, this is not an issue where, if I would just tell myself to relax, I could relax. That's not a thing. I mean, many women come and say, well, my doctor said have a glass of wine and put some music on. Well, that is not going to work, because it's not a conscious thing, So it's something where you really have to teach your body that safety again, so that response can go away.
Got it. Is there any other tools that you use for that, or maybe even after someone had a procedure or something like that?
So that's probably the main tool, but there are other tools. Like, let's say, so some people have pain with intercourse because the very deep off to the side muscles in the pelvis, maybe there's a trigger point there, and maybe it came from stitches or a fall, or there's all different reasons why these muscles can go crazy, but maybe it's really too deep and a straight dilator is not going to reach that. So there are some curved ones that you can instruct them in. So they look kind of like an S, and you can instruct somebody to use something like that. Sometimes it's just, let's stay on the outside and do some self massage of the tissue to make it more flexible and decrease some skin sensitivity you might have. So we might do something like that. Or if some people have maybe a spot that's really painful, maybe we talk to the doctor and see, would some lidocaine cream on this area make this easier for her to progress with the dilators? And maybe we go that route. So sometimes there's medications. It kind of runs the gamut. It really just depends on this patient's situation and what we're trying to achieve.
Do you find people after having like a surgery procedure have a lot more problems in the area as well?
I mean, the most common is going to be if somebody tore during a childbirth and had stitches there, and then they try and become sexually active and they either have pain or they might have leakage. Something happens that those muscles just are not kicking in. Or women that have the 3rd and 4th degree tears, which are obviously affecting more and more tissue, we want to be really extra careful with them, because they may do pretty well right away, but research shows like way down the road, this might be a problem for them. So we really want to make sure that our women that go through something like that know how to care for their pelvic floor so that they don't run into problems later in life. The only other thing I can think of that consistently can show up in the pelvic floor are surgeries like hip surgery. So a lot of my patients that go in for like a total hip surgery or maybe a hip arthroscopy, when the hip muscles contribute so much to the pelvic floor control and strength that they might get a recurrence of their symptoms, or maybe that was the factor that brought the symptoms to begin with. So yeah, sometimes knee, but not as direct.
You mentioned the tailbone several times in this meeting here. So what can you tell me like how that's related to pelvic floor? Because I've had some patients who lose a lot of weight and then all of a sudden they have this tailbone pain. Is that something that pelvic floor therapy can help, or what are your thoughts on all of that?
It can. Tailbone pain is a tough one. There's not one thing I can tell people with tailbone pain. It really takes some focus to evaluate where is this coming from. But the tailbone is enclosed in pelvic floor muscle. So the first thing you want to do is screen the pelvic floor and make sure it's not coming from that. If you do have a lot of tension in your pelvic floor, that tends to pull the tailbone forward. And then when you're sitting and pushing it even further forward. And then you go and stand. So a lot of people with tailbone pain are okay with sitting, but they go to stand and they get terrible pain. And that tailbone's trying to come down a little, but it's kind of stuck forward. And these muscles can really reinforce that forward position. And so if that's the case, then we're going to work on not Kegels, we're going to work on lengthening and relaxing those muscles more. Sometimes during, having a baby, the tailbone might get askew a little bit, or it might just be traumatized because the baby hit kind of on the way out, hit that tailbone. And so now we might be talking more joint. So some pain can actually come from the joint itself. And then there's other muscles further outside of the pelvis that kind of come down and influence the tailbone. And even what your back is doing can influence what your tailbone's doing. So you have to kind of look at that whole area and listen to the history to help guide you for what you need to do. And that's fascinating to me that you said you've had people who have lost significant amounts of weight and had problem there. I would love to explore that and see if I could figure out why that would be. Because I can't, off the top of my head, I'm not sure. Something must change about how they're using their body. But I'd love to see what that is to learn from that.
Yeah, me too. I mean, so would you recommend that I refer patients for pelvic floor physical therapy if they're having that problem, you think?
Yeah. I mean, so if I had somebody with tailbone pain, I would know the first visit whether or not I would be the person to help them or not. Because again, now I can't put my hands on you and it's your tailbone. So I'm going to have to make some assumptions based on your history and how you're moving the rest of your body. And that may or may not be great for tailbone pain, but definitely an in-person therapist would be perfectly appropriate for tailbone pain to assess that too. So I would think mine more of a screening. I'd probably screen someone during that 15 minutes and have them do a few movements to see, do I feel like this is something I can do you justice for? Because we're ethically held to make sure we're giving you the best care we can. And if I think this is just not something I can do via telehealth, I will absolutely tell you and help you find an in-person PT.
Okay. So we've talked about the Kegels and strengthening, and then we talked about the dilators and working with sexual health. Did you tell us exactly what are some ways to lengthen and relax? Like, is the opposite problem?
Yeah, the opposite problem is usually more of a challenge for people because people like to just work out hard, pull things in, right? It's much harder to say, okay, we need to work on your breathing a little bit. We need to teach you how to let go. We need to do a little bit of a Kegel, but then let's actually work on the letting go and focus on what that feels like, because it's easier to ramp stuff up. It's much harder for people to go backwards and ramp things down. There are a lot of muscles in the area, like the groin muscles, some hip rotator muscles, hamstrings, deep tummy muscles if they're too tense and tight. So the nice thing is someone like that that's having difficulty really kind of sinking in and relaxing, you can give them some physical stretches of stretching all the muscles I just mentioned. Stretch your groin muscles, do your butterfly stretches, do the hip muscles and stretch those out, do your hamstring stretches. So it gives them something to gnaw on a little bit and do much more actively. But then you still have to come back and say, okay, now that you're done with that, it should be easier for you to work on your breathing. Lengthen those pelvic floor muscles, visualize vaginally an opening or blooming of a rose, right? So you can use visualization that way too, not just the tightening way. That's definitely a little bit harder, I would say, for most people, but it's so important. And the minute they do that, they start to see, oh, my symptoms are already shifting a little bit. And it's because you've let down that tension pattern and the muscles are able to do a little bit more what they're supposed to be doing. Once anyone gets a little bit of relief, it really helps with motivation of continuing along those lines.
I feel like that leads into pretty good of how lifestyle factors like exercise, diet, and stress can contribute to pelvic floor problems. Would you say that working on stress and like meditation and breathing would be helping that as well? Or how do you feel?
Absolutely.
Like
Especially if you are absolutely. Especially if you are somebody that has those tension patterns. Some things like as simple as, I drink 4 or 5 cups of coffee through the day. Well, that might be impacting your bladder problem. Being dehydrated all the time and not drinking much of anything, that might actually impact your pelvic floor issues. Sitting on your tailbone and in a slouched position because you work from home at your kitchen table and your arms are in a weird posture, your back's in a weird posture, that can certainly impact what your pelvic floor is doing. So there's lots of, they call them like behavioral strategies that we treat, but essentially it's just, okay, how do you use your body in space and in your environment? And how do you treat your body through, for instance, like looking at your diet a little bit and especially what you drink for the pelvic floor? Because there's some simple things there that can really shift some of your symptoms.
You want to give an example of a couple things?
Yeah. The bladder one's probably the biggest. That I talk about this all day long with patients because so many people do things like this. Like carbonated water is super common right now, right? Everyone loves their carbonated water. But I'm drinking water. There's no calories, but there's carbonation. And so if you're drinking 6 of those a day, that could be one of the significant reasons. Even if you're not drinking it at night, maybe that's why you're getting up to urinate at night, because we know carbonation is a potential irritant to the lining of the bladder. So and there's lots, and let's list them quick. Caffeine drinks, coffee or tea, whether or not they're decaffeinated, carbonation for sure, alcohol, and very acidic drinks. Those are probably the most common. And so whenever I'm working with somebody that has any bladder issue, we start with try and get yourself mostly to water. Don't give yourself a migraine. Don't go cold turkey, but let's strip it down and try and get as close to water as we can. And then we'll see what your baseline is. And now add one thing back in. Maybe it's that cup of orange juice in the morning that you like so much because orange juice is acidic, right? And that can irritate the lining of the bladder. So if you put that back in and you're fine, okay, you can drink your orange juice. The next day, put your tea back in that you like to have before bed. Oh, well, now I was up 3 times last night. Okay, well, it might be that tea that you had, even though it was chamomile and you thought it was going to help you sleep. Maybe it didn't help you sleep because it's making your bladder irritated and you're getting up a lot at night. So the only real way is just to try. So it's just this very much trial and error. So you start mostly at water, all water if you can, but you don't want to give yourself a migraine. And then one by one, add something else in so that you can see, okay, these are the things I like to drink. And let's see what kind of effect that has on how my bladder is functioning.
I definitely didn't know carbonation irritated the bladder. So I will bring that definitely to my clinic use. So I was going to also ask if there were any warning signs or symptoms where someone might really be wanting to reach out to you or any other physical therapist, pelvic floor. What would you say? What are the biggest warning signs or symptoms they might be having?
So there's so many myths around what's normal. So people go, well, I had a baby. Of course I leak when I cough or sneeze. Well, that's really, really common, but it's definitely not normal. And over time, pelvic floor problems tend to kind of snowball and you tend to have more and more issues. So if you're leaking a little after you had a baby, get that taken care of. If you notice, oh my gosh, I used to be able to go all afternoon without peeing, but now I have to go like every hour or 2. That's too often. Go take care of it. It's not going to just go away. So go see somebody. If you have any pain with intercourse, that's not normal. Go in to see somebody. If you haven't had a gynecology appointment like we spoke earlier, well, that's going to be your first step. If you have and they've said everything's normal, but you're still having pain with intercourse, see a pelvic PT or a pelvic OT. There are some occupational therapists that treat this as well, so that we can see, okay, what's the muscular component with that? So you should not have pain with intercourse. Let's fix that. If you feel vaginal heaviness, especially when you're on your feet towards the end of the day, that could be pelvic organ prolapse or this pressure coming down. So let's work on strengthening your core, deep core muscles and figuring out how do you deal with pressure. Pretty much anything that's happening. If you're very constipated, constipation can actually be a sign of pelvic floor dysfunction. So if your doctor and your GI people, they've said, oh no, you're fine, there's nothing going on, but you know you're constipated, that could be a muscular problem. So go see a pelvic PT and figure out if that's something that can help. So pretty much anything down in that area from forward to back, you've got your urethra. So anything to do with the bladder. Then you've got the vagina, so pain with intercourse or pelvic pressure. And then you've got the anus. We didn't really talk about that. Maybe you're smearing your underwear after having a bowel movement. That's a very common symptom, very embarrassing because there's scent connected to that, right? And people think there's nothing I can do. I don't know what's wrong. I didn't wipe myself well enough. Well, no, it could be weakness of those muscles. And a lot of times with that comes the inability to control gas. So maybe that's a symptom that you want to take care of too. So all of those things are related to how the pelvic floor muscles are functioning.
Great point about the constipation. I've definitely had to refer some people for pelvic floor therapy due to their constipation and what they were presenting with. So that's really important. And then you kind of already answered this question because you said the word myths, but I know there's a lot of other maybe myths and misconceptions about pelvic floor health. I didn't know if you wanted to throw in any other ones.
Yeah, sure. Yeah, we've mentioned a couple of them. Just like the most common are, well, my mother leaked, so of course I'm going to have problems. Totally not true. Yeah, I'm older, I'm through menopause. Of course, I'm going to have to go to the bathroom a lot. Not true. Again, all these things are super, super common. There was a new study out in 2022 that about 60% of women have leakage. I mean, that's like over half now. It used to be under. It's over half now. So that's how common all of this is. But these are not normal things. These are signs. If you read the signs of your body, these are signs that something is not working correctly. And there's things you can do about that to fix that. And they're not difficult things. There's learning the right strengthening and learning the right behaviors that help this area be healthier. So all the myths around Kegels that we started talking about, that certainly is a big one. And then myths about whether or not you cough or sneeze, is that normal after you have a baby? Again, super common, not normal. So get it taken care of. Those are the big ones that are kind of popping into my mind right now, the most common ones.
I do think people are, or at least depending upon the age range, but I think more younger people after having, childbirth and things like that are having the symptoms, are reaching out to the providers. But I think a little bit older generations definitely have thought that it was normal, like you're saying. And then unfortunately, they didn't seek help, or now are struggling even worse, when maybe had they taken care of it earlier on in life, it might have not be as burdensome for them. So I think it's important to make it okay, like you're doing in their telemedicine, to reduce those barriers to get these patients seen and in and get their quality of life better.
Exactly. That's exactly been my experience too. And it's harder to get some older people to take action because they so strongly believe, well, everyone they know has that issue too, if they've talked about it. And they think that there's not going to be anything that you can do. And they're embarrassed. It's also from a generation that's not used to kind of living everything out like the younger generations now, So there is a generational difference for sure. And the younger generation has more anxiety because they know too much. So I've never, in 10 years, I never had anyone ask me about an abdominal diastasis. And now that's an everyday occurrence. Do I have a diastasis? So how do you know what that is? It's such a weird name, but because they read more, there's a little more anxiety about what I might have happened to me. It's a little double-edged sword, but I think overall it's much better to know and then deal with it.
Yeah, I think Dr. Google and social media have also helped them be more aware of what problems they could be having, which is good, but also maybe could create more anxiety. So do you want to share a success story? Do you have any?
Oh, gosh. Yes. Tons. I have someone that took a class for me a while ago. So her history is that they had kind of this in their family. We all have small bladders. This is like what they thought. We always have to go a lot. That's just our norm. We always have to leak because mom leaked. So in their mind, this was a familial thing and this was their destiny. And so she took a class from me. So I have some online classes. And at this point, I was doing a live class that she was in. And she explained all this history. We all talked very frankly about what was going on in our lives. It was almost like a little support group. And so we were challenging some of those assumptions. And the whole class was about how to learn how to handle urgency and going to the bathroom. And you have to get control over it before you can start saying, I'm not going to go as often. And so there's a big emphasis. We have to really emphasize, here are specific things to do to shut your bladder down and get you in control before you head to the bathroom. Once you get good at that, you can then go less often and less often and less often. So now she still emails me saying, I sat through a 3-hour movie and I didn't have to go to the bathroom because all these years she just thought she was going to be stuck with it. But she learned the tools. She was very good at doing it. You have to actually do the homework too,
Right.
which most people are pretty motivated to do it because they're having issues or they wouldn't have come to see me. But so she really put in all the work. She can now go 2-3 hours, no problem, where she was going under an hour every time she had to pee. It was less than an hour. She's getting up at night 2 or 3 times at night. Now, sometimes she sleeps through the night. Her dog wakes her up to get up in the morning. So that's kind of an example of a bladder one that she really had quite an overactive bladder, and she had really the wrong assumptions. She assumed she was just stuck with this because of the rest of her family, how they felt about it.
I like that story. I definitely don't want people to be just saying, oh, my mom had it, I'm going to have it. So yeah, that's definitely heartwarming that you can help make her life much better. And she can last through a movie. Very important.
Exactly. Now that it's all open again, right?
I know, right? So is there any last words? Any advice or anything for anybody?
Oh gosh, just don't hesitate. Don't hesitate to see a pelvic floor therapist. We've seen it all. We've heard it all. You're going to be mortified and embarrassed to start talking, but I promise you, the second you open up, all of a sudden the words just keep falling out of people's mouths because they're so happy to have somebody to listen and understand what problems you've been going through. So if you're hesitating at all, just do it. We have lots of training. Again, we've heard it all. And so we want to be able to help you, and we know what's possible for you. So once you trust us enough to kind of let us in and tell us what issue you're struggling with, there's really quite simple things that we can then teach you to take care of those problems, and they can be so life-changing. So that would be my last word, is please just do it. Like Nike, just do it.
Perfect advice. And where can people find you?
So the name of my private practice is My Pelvic Therapy. So they can find me at mypelvictherapy.com. And like I mentioned earlier, I do free consultations with anybody who is interested so they can get to know whether or not this is for them. And I'm licensed currently in 4 states. So I'm licensed in Florida to treat via telehealth. I live in Illinois, so I'm licensed in Illinois and Colorado and California.
Awesome. We will put all that information in the show notes. Thank you so much for coming on the podcast today, Angela. This was very enlightening. And I hope everybody got a lot of good advice here, and we'll tune in next week.
Sounds good. Thank you so much for having me. I enjoyed it.
Thank you.